Welcome, ladies and gents, to yet another episode of the NailedIt Ortho podcast, where it is our job to talk about, different orthopedic injuries and conditions, and try to at least get you all well versed, just so you feel comfortable managing it, and maybe even answer some questions on it. I am one of the hosts, Dr. Cole, and I'm accompanied here with my co-host.
Hey guys, it's Dr. Jamal Fitz back in today.
Oh man, and we're back again for another one. This time we're going to be talking a little bit about ACL injuries, but I'm going to go ahead and let my co-host here, Dr. Fitz, do this rolling introduction.
Yeah, absolutely. I'm actually really happy to introduce our next speaker. He was one of my first mentors that I probably ever had back in medical school. It's Dr. Nicholas Bonniag. He's an orthopedic surgeon that specializes in sports. Did his residency at the University of Cincinnati, his fellowship at the Campbell Clinic off in Memphis. He's coming today to speak about ACL tears and ACL injuries. And I know that's a pretty hot topic, one that, all the sports guys like to talk about. Everybody who's interested in sports kind of look into it. So I hope you guys enjoy it. Just a little disclaimer, he was nice enough to actually let us into his home. We actually went out to Marietta and hung out in his house. So there's a few extra guests on this podcast. Some of his lovely, just hanging around. Some of his lovely kids. So hope you guys still enjoy it though. All right.
You are now listening to Nailed It, the Orthopaedic Surgery podcast, featuring Doctors Jay Fitz and Wendell Cole.
Bonnaig, thank you so much for being on the show. Really appreciate it.
Happy to be here.
Of course. Again, it's me, Dr. Cole,
and Dr. Jay Fitz.
All right, so we kind of wanted to start off just asking you some questions about yourself, trying to get to know you a little bit, and then we'll go ahead and dive deeply into the ACL injuries. Cool?
Yeah, absolutely.
All right, so the first question is, if you can go back and give your 25-year-old self some advice, what would you say?
Well, that's a great starting question. 25-year-old self, so that would be me finishing up medical school, right? Because you guys are about that age. Yeah. I would say travel as much as you can before you start to have a family. I'd say learn as much as you can about everything, and really just get to know the world, get to know yourself before you get into this kind of journey of life where you're going to be working and working very hard with long hours, and things get really busy.
Okay.
Yeah, it's a good one.
Second question. Name one book that has changed your life, and how did it change it, if you can think of one?
Yeah, that's a great question. I think the book is by Malcolm Gladwell, and it is a book about success. I'm looking up the title real quick.
We definitely put you on the spot right there, so yeah. I understand on this one.
The book is called Outliers.
I have that book. I know what you're talking about. I haven't read it.
And it's just a book about how many hours it takes to kind of perfect a craft and be good at something. The magic number is 10,000 hours, but it kind of goes through the journey of how to get there and what it takes. Actually, my chairman, Dr. Stern, bought that book for me during residency, and so that is definitely a book that I constantly refer back to.
I might have to add that one to my Amazon cart tonight.
Yeah, I might need to go do that.
And then there's another one. It's about mindfulness and meditation as it pertains to medicine. I'll have to get you the author of that, but that's also another book that I'm reading now that they can be very helpful with the patient experience.
That's great. Love that. Thank you. And the last question, beginning question we have is, do you have a quote that you live your life by, and why?
Getting deep.
That is getting deep. So the one that I kind of gone by and try to live my life by is by, I think it's T.S. Eliot, and it's only those who go so far can figure out how far they can go. So basically, it's like, unless you take chances and really, push yourself to the limit, you really won't know what you're capable of. So really just kind of get after it, kind of quote.
Nice. I love that. And the last thing here, so we typically kind of want to do like one-liners, right? Like you go to a hospital and you see a patient and like, this is a 34-year-old male with X, Y, and Z. And we want to know what yours is. So, for example, mine is I'm a 25-year-old male. Now I'm a 25-year-old doctor. And I like to hang out with my friends, like to hang out with my family, and I love to travel. Or Dr. Fitz would be
27-year-old doctor, enjoy living life to the fullest, traveling, spending time with my loved ones, and looking forward to embarking on this new journey of orthopedics.
So with that, what would your one-liner be?
Yeah, so I'd say, I'm a 35-year-old male who's passionate about everything I do, and my biggest priorities are family, faith, and education, and I try to live by those.
Love it. Awesome. Now let's dive deep into some ACL injuries.
Yeah.
So we love to start off with a case and then kind of just go from there. So let's just say somebody comes into your office. It's a 25-year-old male, and he comes in for knee pain and swelling. He said the pain started yesterday. He was playing basketball, twisted his knee, and heard a pop, couldn't finish playing the game. Mm-hmm. Now he came into your office. So what are some of the things that you kind of want to look for on history and physical exam?
Yeah, so you kind of laid it out for me, but yeah, you look for mechanism of injury. So basketball, he's obviously had an acute injury, felt a pop, swelling. So that history there, you kind of look for, that kind of leads you down the direction of possibly a ligament injury like an ACL tear. You may ask about symptoms, does the knee give out on you? Does it buckle? Were you able to go back into the game and play, or did you have to sit out? Is this the first time this happened? Is this an acute injury? Is this something that you've been dealing with a few years ago and now it's recurred? And then after that, a big thing is the physical exam. Obviously, you want to look at the knee. Is there an effusion, so fluid buildup in the knee? What is their range of motion? And then probably the biggest thing is you want to look at a Lockman's test, which is to test the stability of the knee and figure out whether the ACL is competent or not.
Right. And the Lockman test, for those that are listening, that most of them should know what a Lockman test is, but if it's not, how would you describe what a Lockman test is, if you had to explain it out?
So a Lockman test is used to determine whether there is an endpoint when you stabilize the femur and try to pull the tibia anteriorly. And it's done with the patient supine, so on their back, with the knee in about 20 or 30 degrees of knee flexion. And you're looking to see if there is or is not an endpoint. If there's an endpoint, that means the ACL is intact. If there's a soft or what we call mushy endpoints, high suspicion for an ACL tear. Big thing is you want to compare it to the non-injured leg to see if there's any difference. And there's a grading system for Lockman. Grade 1 being less than 5 millimeters of translation, meaning the tibia moving 5 millimeters with respect to the femur. Grade 2 being 5 to 10 millimeters, and grade 3 being greater than 10 millimeters. And then they've got a subpoint, which is A or B. A meaning a firm or firmer endpoint, B being a soft or no endpoint.
Right. Now, I've seen a lot of people do the Lockman's exam, but I also know there's an anterior drawer. Now, do you typically use that exam as well, or do you kind of generally go with the Lockman?
I don't, and the reason I don't use it is that you can be fooled with that test because if somebody has a PCL tear, posterior cruciate ligament tear, and the knee is already sagging back, when you pull it up, you may think you're getting an anterior draw, but it's really that you're just reducing the tibia. And so I don't feel like that test is that sensitive for that reason. The other reason being you've got somebody who just tore their ACL and they really can't bend the knee that well. You're asking them to bend their knee to 90 degrees to test it. A lot of people won't tolerate it. And so that is, it's tough to kind of get that test accomplished in the exam room.
Okay.
And also, just since we're talking about some of the special tests for the ligaments, are you familiar with the pivot shift test as well?
Yes.
Do you ever use that?
So that test is another one that's pretty difficult to elicit in the office just because of pain and swelling, but it is something I use constantly in the operating room before we perform the operation, just to get a good idea of how unstable the knee is. It's more of an academic exercise, for me, because by that point you're in the operating room. Obviously, you've got a physical exam, you've got an MRI that confirms the diagnosis. I use it more if there's a partial tear in the ACL. I'm not sure if they're going to need a reconstruction, and it's something that can help in the decision making, but it's not the only test that I use.
So once you do the physical exam, you kind of just touched on it a little bit there. So once you do the physical exam, you do your special tests, which are, positive. What imaging do you want to kind of look for? What do you order after that?
So we usually start off with x-rays, and that's usually rule out any fractures, make sure they don't have arthritis. Sometimes you can get something pathognomonic called a Sagan fracture, where it's like a capsular avulsion on the lateral side. That's not always, but usually if you see that it's pathognomonic for an ACL tear, I start off with x-rays. That's my first start.
What use do you have for the MRI in this type of injury as well?
Yeah, so I'm pretty aggressive at ordering an MRI, just from the standpoint of wanting to confirm the diagnosis and then rule out any other issues, rule out a meniscus tear, rule out a tear to the PCL, the collateral ligaments, posterior lateral corners. So I'm very aggressive at ordering an MRI if my suspicion is for an ACL tear.
And when you do order an MRI, how do you systematically approach the MRI when you're reading the knee, when you're looking at the knee films?
Yeah. So I think like anything in life, you want to have a good system. So for me, I usually start with the sagittal slices, and I start on the lateral side of the knee. And you're looking for a bone bruise pattern. And then usually the bone bruise pattern is on the lateral side of the knee, a posterior lateral tibial plateau, and the kind of mid-third of the lateral femoral condyle. If you see that bone bruise, then it's almost certain that because of the rotational injury, the patient has torn their ACL. I go towards the middle of the knee and look at the ACL, PCL. As I'm scrolling through, I look at the menisci, both laterally and medially. And that's usually I start with the sagittal, and then I'll look at my coronal views to look at the collateral ligaments, so the ligaments on the side of the knee. Make sure that there's not an MCL injury or a posterior lateral corner injury. And then you're able to look at the bone. But I think the big thing with the MRI is just having a system.
Right. Okay. And so once you've done that, we've done our physical exam, we got our MRI, which confirms that the patient has had an ACL injury. How would you describe that to the patient? And then how would you describe that amongst, I guess, residents and physicians and, the different bundles, et cetera, of the ACL?
So, yeah, to the patient, essentially, it's a tough discussion to have, but basically, I tell them this is what's going on. A lot of times before I've ordered the MRI, I explain to the patient why I'm ordering the MRI. So it's not as much of a shock to say, hey, you sprained your knee, we're getting an MRI. That's not your discussion. Hey, I have a suspicion that you tore a ligament called the ACL. I want to get an MRI to confirm that. And so a lot of times it's the first thing. And then the discussion from there basically is, what are your activities? What are you hoping to get back to? And from there we can discuss whether it's somebody who may be a surgical candidate or somebody who we treat non-operatively. As far as, I don't work with residents. I'm in private practice, but as far as with residents, I mean, the biggest thing again is, with any, you want to know anatomy. So anatomy of the knee, what does the ACL do? Again, treatment options, and then what are you hoping to restore with surgery so that the patient can go back to?
Absolutely. So I guess that's a good point to transition on to treatment options. So I guess how do you determine where you would like to go as far as with the treatment for these type of injuries? Yeah.
So a lot of the treatment discussion is based on what the patient's goals are for. So if you have a 25-year-old kid who injured the knee playing basketball and hopes to go back and play basketball, then I'm more aggressive at recommending surgery because the ACL is necessary to do any pivoting, cutting, shifting movements. If you don't have an ACL, it does increase your risk of tearing the menisci, so either medial lateral meniscus or injuring the cartilage. Conversely, if I have a 70-year-old male or female who slipped on ice, tore their ACL, was just putting some groceries in, and really not active besides doing some light jogging or walking around the track, no sports, I'd be more likely to try to steer them towards non-operative management with physical therapy, bracing, activity modification.
Absolutely. Well, and also just since we're on this point, at this point, say this was a much younger patient, maybe a 12-year-old patient. You looked at the x-ray and you saw that his physis was still open. Does that change the treatment plan or options anyway?
Yeah. So if they've got a complete ACL tear, it's a skeletally immature patient. A lot of times we're definitely recommending surgery, just because again the risk of injury to the meniscus, chondral injury, and those kids are going to be some of the most active. The biggest thing is just realizing that again the kid is skeletally immature because some of the adult type techniques that are being used cannot be done in kids because of the growth plate.
Okay. And you always lead us on to in a good way. So what are some of the techniques that you use as far as some of the surgery options for ACL tears?
So ACL tear, so there's two main options. You can take because you cannot repair the ACL and put stitches in it because there's the ends of the torn fibers heal with some fibrous tissue that is not amenable to repair. We recommend the reconstructing, meaning giving you a new ligament. And there's a couple options. You can take the tissue from the patient's own body, called an autograft, or you can take the tissue from a cadaver, called an allograft. And there's advantages, disadvantages of each. As far as taking it from the patient's own body, the biggest advantage is there's no risk of disease transmission. And if you look at the literature, there's a lower retear rate, particularly in kids under about 25 years of age. So lower retear rate, no risk of disease transmission, tends to heal and incorporate a little bit quicker. The disadvantage of taking it from the own tissue is it's essentially, I'm not going to say two surgeries in one, but there is some, harvest site morbidity, having to take tissue from somewhere else. So there's always, inherent risk with that. As far as taking it from a cadaver, the surgery is a little bit quicker. Smaller incisions, but there is a slight risk of disease transmission. Depending on the tissue bank, those risks can be very low, like 1 in 1.6 million, but still theoretically a risk. And then, assuming that we talk about your case here, the 25-year-old, a lot of times I'm recommending that the patient take it from their own body and autograft because to decrease the retear risk. And then there's options as far as taking it from the bone, patella tendon bone, or taking it from the hamstrings, or even the quadriceps tendon. And so I have a discussion with the patient, but I have a preferred technique, which is a bone, patella tendon bone. A lot of it's biased just by how I was trained, but also if you look at professional athletes, which is the most common group getting this reconstructed, a lot of them are getting the bone, patella tendon bone, because you're putting bone in a tunnel with bone, so it tends to incorporate, I think, a little bit more quickly rather than relying on soft tissue to heal the bone. But if you look at the literature, there's really no difference in terms of which graft to use. You just want to use one that you're most comfortable with. Yeah.
And what are some of the common, I'll say, what are some of the common mistakes that are kind of seen in these surgeries? So when you're doing an ACL surgery, you're doing BT bone to bone, using patella autograft. Like, what are just common things that might not even just be patella surgeries, but just in ACL reconstructions in general?
Yeah, so the biggest, error as far as technical error is just putting the tunnels in the right location. Because, you can put them incorrectly and it can lead to complications like stiffness, instability with rotational movement. And so tunnel malposition is probably the most common complication, technical error. You can get some stiffness afterwards. That's not necessarily related. It can be related to surgery, but not always. Then, inherent with, specific grafts, with bone, patella tendon bone, always at risk of, patella fracture, or with hamstrings, amputating the tendon. But the biggest issue is probably the tunnel position. So you want to make sure you see somebody who's comfortable doing the ACL reconstruction.
And what would be a good aiming point, I guess, for the tunnel? And what is a good tunnel position that you should be aiming for?
Yeah, so the biggest thing is on the femur. Okay, you want to traditionally there was a technique where you drilled the femoral tunnel or socket through the tibia, what we call transtibial technique, and that tend to put the graft a little bit more vertical, or at the 12 o'clock position. And what we're finding is that you want to try to get the graft a little bit more horizontal to correct or control some of the rotation. So, you're looking at more of a 9 or 10 o'clock position, or 2 or 3 o'clock position, depending on which knee it is. So basically a little bit more lateral on the wall versus more vertical. And then you want to make sure that you're posterior enough, meaning you're close to the edge of the femur on the backside, but not through it. So usually what we say is about 1 or 2 millimeters of cortex on the back wall.
And you're talking about when we're starting off the drill.
Exactly.
Okay.
Exactly.
Yeah, I was just going to ask. So, because this often happens in athletes, and they go back to playing again, and sometimes they have re-tears and different things like that. Is there anything that you have to do different sometimes if it's happen to be a revision surgery, or if they had a prior ACL surgery previously?
Absolutely. So if it's a re-tear, the biggest thing is finding out why did they re-tear. Is it were the tunnels put in the wrong position? Was the wrong graft used? Or was it just unlucky? And so, that can be determined by getting additional imaging, like a repeat MRI, CAT scan, and then getting a good history from the exam, a history and physical, making sure that another injury wasn't missed, like a PCL tear or posterior lateral corner injury, something else. So that's really want to take your time and get as much information before kind of jumping back into the pool.
I'm actually glad that you mentioned that. So for some of these athletes who might have, or just common people, if they have associated injuries like the meniscus or PCL, is there, I guess, does that change the treatment plan in any kind of way?
Yeah, I mean, it does. Not every PCL tear requires surgery, but if there's a complete PCL tear, that may require reconstruction of the PCL as well. And so that's something where you again want to have a discussion and review the imaging. The biggest thing is that you don't want to make a decision based on just the MRI. You want to examine the patient, because you may get a read of an MRI where it shows a partial PCL tear or grade 2 PCL tear, but you examine somebody and do a posterior draw and the knee feels very stable. And so you don't want to do unnecessary surgery or do surgery that may not necessarily address the patient's symptoms.
Absolutely. That's actually exactly what I was wondering. So other than that, I mean, with the revision surgery, say you do it, you've done it the second time. I guess, is there a certain point where you just stop doing these surgeries, or you have to start thinking of something different?
Gosh, I mean, thankfully I haven't gotten to that point of seeing that yet. Knock on wood. But I mean, certainly I guess there's a point when you stop, but you really have to figure out why. I mean, if they're developing arthritis in the knee, that is a good reason to say I'm not going to continue to reconstruct the knee. Maybe somebody who's candidate for, some type of arthroplasty surgery. But again, you got to look at age. You got to look at a lot of variables. Certainly, if there's somebody who's got a history of infection or blood clot or some other medical issues that may make surgery unsafe. But we try to do our best to kind of recreate the anatomy and get somebody back to their activity level. So you don't hear of too many of those episodes.
Yeah. I kind of had more of a general question, but I know, I guess back in the day, used to be a lot of people used to do like the double bundle ACL reconstructions, and I guess they're supposed to. Well, I guess this is my question. So, in the double bundle, could you tell which one would be the anterior medial bundle and the posterior lateral bundle if you use a cadaver, or how does that necessarily work?
So there's some areas of the country where that was pretty popular. I don't know if it's as much now. And basically, the ACL is made of 2 bundles. There is a posterior lateral bundle and anterior medial bundle. And so, when you're doing a reconstruction, it's hard to really have both bundles as separate entities. So you can put it in a place where you kind of get the best of both. And then there's been some studies where maybe you try to do 2 bundles. It's technically very difficult to do, which is why it really hasn't caught on. And clinically, I don't know if there's much. I mean, clinically, so if you've got 2 patients, one that's a single bundle and one that's a double bundle, we don't know that one necessarily does better than the other. So if there's no difference clinically and one is a little bit easier to perform than the other, then it would make sense to try to do the more technically reproducible surgery. So I don't think that's as much popular now. If you use a cadaver graft, you can certainly have it constructed to be 2 bundles, but you still got to drill those tunnels, and it just sounds pretty straightforward. But again, there's some things that can go wrong. You mentioned enough technical complications that can occur with a single bundle. the dumbbell bundle, that's also even a higher risk.
Now I did have a question that I forgot to ask earlier when you were talking about the Lockman test, because we talk about the two different bundles, about the anterior medial and the posterior lateral. Yeah. I heard that the anterior medial bundle is tighter during flexion. So is that when you're doing the Lockman test, and are you mostly testing the anterior medial bundle?
Yeah, I mean, I guess you could say that. The biggest bundle that's responsible for stability is the posterior lateral bundle. So it's really, when you're doing the test, I'm not really specifically looking for a specific bundle. But yeah, in theory, that is a good point. I mean, that anterior medial bundle is tighter in flexion, so you are checking that. But when you do the pivot shift test, again, that's a good way to isolate the posterior lateral bundle and see how competent that is. So the bigger one is the posterior lateral bundle as far as rotational stability.
All right. And I guess so when we have this patient, we diagnose them and they've had their treatment, they've had their reconstruction, what are we looking at as far as rehabilitation time for these patients?
Great question. So rehabilitation, I tell people, is a minimum of 6 months. I start my patient to physical therapy the day after surgery, working on trying to regain the range of motion and then building up the quadricep strength, which takes up the majority of the time during physical therapy. So a minimum of 6 months, but depending on what type of activity you go to, I take care of a lot of collegiate athletes, and if they injure their knee, a lot of times even at 6 months they're not even going to be eligible to go back. So sometimes it takes the full 9 months or even a year. So everybody recovers a little bit different. You're all hear about Adrian Peterson being able to kind of go back in 6 months, but that is not the norm. He's a freak.
Yeah,
so,
absolutely.
Yeah.
Well, I mean, I think this was great. This was a great talk, and I mean, I think that's a good way to end it. I like ending it on a little comedy there.
I like Adrian Peterson.
Yeah, everybody like a little AP.
Absolutely, yeah.
But before we go, Dr. Bonnaig, we always like to tell our listeners a way to reach our speakers, our guests. So what's the best ways to reach you and find out more about Dr. Nicholas Bonnaig?
Yeah, so, we're on our website. I'm with the group Pinnacle Orthopaedics in Marietta, Georgia. So it's www.pinnacle-ortho.com. And that's one way of just looking up our website. And then my personal email is just my first initial last name @gmail.com if anybody's got any questions.
And just so they know, can you spell that out for them?
The
email.
N and then B as in boy, ONNAIG @gmail.com.
All right. Well, there it is. Thank you so much for being here with us today, Dr. Bonnaig, and thank our listeners for listening.
Yeah, thanks for having me, and congrats to you guys on a exciting time ahead.
Thank you all for listening to yet another episode of the NailedIt Ortho podcast. I hope you enjoyed this great overview of ACL injuries. I feel like, hopefully after listening to this, you're able to kind of triage and see these patients in clinic and kind of have a better idea of what's going on, the treatment plans, and, even some of the thought process behind surgery. Mm-hmm. Now, if this is your first time listening to us, don't forget to subscribe to the podcast and give us a rating and leave us a review. Write down your thoughts and your feedback, and we love to hear it. So follow us on Instagram also at NailedIt Ortho. And if you have any questions and you want to reach out to us, our email is nailedItOrtho@gmail.com. Until next time.